aspiration pneumonia. The median life expectancy drops to about 6 months. This lady's MMSE was 11, so she could live a little bit longer, in the range of somewhere in the range of 2 years.
So, when you're having this discussion, would you already have assessed the resident?
Yeah.
I'm bringing up the point because sometimes we have the tendency to say, well, yes, they're unsteady, and we'll do our best to prevent the fall, but people fall, and we'll just have to see, if we can, remind her to take a walk or something like that. And as far as the eating, well, with dementia, people tend to eat less, whatever. But in this context, you already knew that she was on a lack of medications which could contribute to this. So when you're having that goals of care discussion, would you have brought up that, you're going to review her meds, maybe there's some reversibility in this, or you just kind of get the family's impression and not kind of react to what they're saying?
So this is a case conference, and this is also some discussion along the way. So I'll see a new resident or a new patient I have, I'll do an assessment, a comprehensive assessment, and we may do it over a couple of stages, like we talked about last time. You may not do it all in one go. You may break it up into 2 or 3 parts. Say, okay, here are the problems that I'm gleaning from this, looking at the whole picture and the history and the drugs, being a doctor. I'm a doctor. And there'll be some discussions with the family along the way, like little snippets about collateral, information and what are your priorities. And then we sort of bring it together again at the care conference. So this is, the next thing is to do what we call what I call drug reconciliation. And I always, you guys are going to take on new people in care homes, and they're going to be on a whole whack of drugs that you didn't put them on, especially if you're taking new people on, and trying to figure out what is the indication for each of those drugs. So in this lady's case, she was on 30 milligrams of oxazepam, and I'm presuming it was for insomnia. She was on 16 milligrams of galantamine for dementia. She was on risperidol 0.5 milligrams BID, and she had a history of agitation, aggression, paranoia in the community, and the family indicated it really helped, to a situation which was a crisis, and it brought the crisis under control. She was on citalopram 20 milligrams for depression and irritability, and they found that really helped her mood. And that was started, around the time the risperidol was hard to determine what was what. She was on flodipine 10 milligrams for her blood pressure, hydrochlorothiazide, 25 milligrams, that should be hypertension. She was on atorvastatin 20 milligrams for hyperlipidemia. I tried to look back, there was no history of stroke that I could find, and there was no history of ischemic heart disease, so this is what I would call primary prevention. And I went back and looked at the CTs, and she had atrophy in her brain. She was on aspirin 81 milligrams, and again, that would have been for primary prevention. There was no indication of an event of having happened to try to reduce it. She was on 1,000 milligrams of metformin twice a day for diabetes. She was on allopurinol. And the allopurinol, I went back and asked them, did she ever have gout in her foot or gout in her ankle? There's a difference between treating hyperuricemia and a difference between treating someone with clinical gout, trying to prevent attacks. And they said, in fact, she'd had gouty arthritis. She had it in her ankle, she had it in her toes. So the allopurinol, and since she's been on it, she hasn't had any problems with that. She was on alendronate, calcium, and vitamin D for osteoporosis. There was no known fracture. So this was based on bone mineral density testing. And she was on the macular degeneration vitamins, the AREDS vitamins, and she had a history of dry macular degeneration. Okay? So how many drugs is that? Who can count quickly? A lot. So the other clinical findings, her blood pressure was 124/64 sitting, and it dropped down to 106/60 standing. What do people think about that blood pressure in an elderly woman? Pretty low, yeah. And there's also postural drop, which adds a certain level of risk to it, doesn't it? The risk of falling. Her hemoglobin was 104, and her ferritin was 30, which was low. And the lab has a fairly low cutoff, I think, for elderly people. But this was certainly low normal. And her B12 level was normal. Her hemoglobin A1C was 5.5. What do you think about diabetes control?
She is anemic. That's number one. That's why A1C is low.
Pardon me?
She is anemic. A1C is dependent on hemoglobin. So that's why hemoglobin A1C is 5.5.
Yeah.
Because she is anemic.
Okay, so the A1C is partly affected by the hemoglobin level. I'm not aware that that's a big factor.
That's a big factor.
It is?
That's
Okay.
often missed.
Okay, but anyways, the A1C, let's say the A1C was 7. Okay, let's say it was higher than that. Would that change? You know, I just want to put that thought in your mind. And then her GFR was 54. And I would strongly encourage you, you know, when you get new residents, you know, I see a GFR as mandatory. You know, like going with the renal function, because almost most drugs are treated through the kidneys, right? And hemoglobin is a good thing to, you know, to have on people as well.
Yeah, I called a nephrologist that I worked with on projects. You know, I saw someone, maybe it was like 40 something.
Yeah.
She said, oh, don't worry about it, they're all like that. So sometimes it's hard to interpret. I'm not saying, of course it's right, you have to be careful. And I was concerned, I didn't know the pattern, I didn't know how that changed, and whether it's just, you know.
In fact, the GFR is calculated based on age and weight and, you know, the creatinine, right?
But you want to see the change over time, and you know, often we don't have that, we just have an isolated value, so.
Exactly, but it tells us that your renal clearance is low, right? Even for their age. Most people will have reduction in GFR as you get older. But I see a lot of people in their 90s with GFR is 90, you know, is normal. But so it tells us, again, puts a blinker on. So, are you going to take a machete? Or are we going to slash through this list here? What are we going to do with this for this lady? And the questions I want to ask you is, there's a couple questions. A lot of these drugs she was on for a long time, and I want you to think about this, is why would a long-term drug suddenly cause adverse effects? So for example, she's on metformin. She's been on it for 20 years. No problems at all with it. What kind of problem can metformin cause? How does it affect how you feel?
Diarrhea.
What else? Diarrhea, definitely. What else? Anorexia, nausea. What's one of this lady's problems? Nausea. She's not eating. Right? She's anorexic, she's not eating, she does not enjoy her food. Most people would say enjoying food is an important part of quality of life. So why would suddenly the metformin become a problem? Could it become a problem?
Change of environment.
Change of environment, anything else? The renal function, it's distributed through the kidneys, right? So suddenly her renal function and GFR has dropped from 90 or 100, you know, and then boom, it's come down to, you know, whatever she's on diuretics and it's dropped, metformin levels can increase and people can get nausea, right? So the things that happen to people Chris alluded to as we get older, why do these drugs that were so well tolerated for so many years, then the patients, families will say, and the patients will say, I've been taking this forever, what are you talking about? You know, that this is not causing a problem, can suddenly cause problems, but there are very good reasons. GFR drops with age on everyone, right? What other things happen with age to people that can affect their drug metabolism?
Hydration.
Hydration could get dehydration, which can affect the renal. The body water to fat content changes, right? So water-soluble drugs, there's less room for them, you know, and the volume distribution of drugs changes. So there's pharmacokinetic things that will happen to people and storage issues. What else happens to people as they age?
Weight loss.
Weight loss, there's less muscle mass, right, and less weight, you know, so muscle would be a sink for some medications. And what happens to the brain as it ages? It shrinks. So the pharmacodynamic changes, right? So someone who could think of ourselves, I used to be able to, you know, get back 2 beers and not even feel it. If I have a beer now, I feel like I've had 2 beers when I was 20, right? Because our brains change, the dynamics change, all those other factors change. So if you layer on a drug that was, you know, for oxazepam 30 milligrams for sleeping, which that's what they needed 25 years ago, and now their brain is shrunk, that oxazepam may have a much more profound effect on their memory and balance.
Especially in combination with the other.
Exactly, and when you layer on, and then the third part would be the drug interactions, you know, when you're layering on different things. So we're going to start to take this lady's case apart, and I want you to think about how would we prioritize our changes if we're going to make changes. What do we taper, what do we stop? How do you go about tapering, and what kind of follow-up do we need? So here's our case, and these are the medication lists for everybody. These are the indications that we've established for them. These are the problems that were identified at the care plan, right, and at the goals of care. And these are clinical findings. So I'm going to come over here, and what are you guys going to do for this lady? What should we be doing for her? What do you see as the problems, and how would you prioritize?
Well, decrease your blood pressure meds.
Okay, so blood pressure meds. Why would you do that, Jeff?
Because she's got a postural drop, and she's very low for a person of her age.
Her mean blood pressure.
Okay. And what's the risk of blood
Falls.
pressure? Fall, right? That's our outcome, right? The blood pressure is an intermediate outcome. Besides falling, what else does low blood pressure make you feel?
Too tired.
Fatigue. People, they don't feel well with a low blood pressure. And so what blood pressure meds would you think of?
HCT.
Okay. And anything else? Okay, so we've got another problem here. We've got edema, right? And stasis dermatitis is a problem for this lady. So fluidity. Okay. And anything else that could affect her blood pressure?
Just like, before we stop the hydrochlorothiazide, is it going to make her edema worse?
Good.
So we need to put that as a watch for.
And put a question mark on that. And it's going to come down here. This is the complexity, right?
We call it balancing factors or whatever, right? On balance, I kind of say on balance. So something else might happen.
Yeah, you have balancing factors, and then you have things I'm going to watch for. You have to keep a running list of all the things I'm going to watch for.
Okay. So we've got two offsetting things here. Felodipine drops her blood pressure and can give her edema, right?
Yeah.
And hydrochlorothiazide is protecting her from weeping legs, possibly,
Yeah.
right? How would you go about choosing which one you would stop first?
Can I just ask a question I've been meaning to ask you for years, which is the edema of felodipine or all other ACEs, can you tell if it's different?
CCPs.
Or
CCPs.
CCPs. Can
Calcium
you tell
channel.
if it's different than heart failure edema just by the texture of the leg? Like, is it a different?
Not to my knowledge. It's pitting edema.
It's always pitting, okay.
So if you know that this one causes edema plus blood pressure, and this one is protecting the edema, which one would you stop first?
There's also potential for hyponatremia, and we see that so much, right?
Okay, so there's a potential. Her sodium was normal. Okay. Yeah. But what would be the risk? Which one would you choose here? Because you brought up.
That's right.
Okay, exactly.
Okay.
So, right, so this becomes into the issue of where do we start?
That's right. Yes, felodipine.
Right? So staging. So that would be a pretty good one to start with, wouldn't it? Felodipine. Okay. Anything else affect your blood pressure?
The other wrinkle in that is hydrochlorothiazide is going to improve, it might improve her GFR. And other nephrologists always really like the calcium channel blockers, so that's just an added little.
Okay, but you're her doctor.
Okay.
And you try and get a nephrologist on the phone. Okay, so this is real world, in the trenches, roll up your sleeves, down and dirty.
I mean, I'd be more concerned about renal perfusion than.
Exactly. Yeah, hydrochlorothiazide actually impairs renal perfusion.
Yeah.
Right? Okay, so that's another thing. So it may help with GFR. So we put here, one of the problems is your GFR is a bit low, which may be affecting all of our medications, right? So stopping HCTZ may help that. And our GFR may come up. Any other drugs could affect your blood pressure?
Wouldn't you reduce both of them? That's what I would do.
Okay, we could.
Reduce, instead of stopping either one, just reduce both of them. 12.5, that's a very high average dosage. And reduce your felodipine to 5, and then measure it again. Measure the ideal albumin creatinine ratio in a few weeks' time. See how she's doing, see what her blood pressure is doing, and then consider stopping.
Okay, so Chris, I think that's an excellent way of thinking about things. There's no hurry, unless there's a real risk. If she's fallen, you need to act quicker, right? Like measuring risk. But the idea of reducing and seeing what happens. The albumin creatinine ratio, I'm not interested in a person in a residential care. What's the risk of her getting renal failure from proteinuria? Or, sure, albumin was normal, we'll say for the sake of argument. Sorry, Megan?
The psychiatric medications.
Pardon me?
The psychiatric medications can lower the blood pressure.
Yeah, so blood pressure, just to finish that, like I like to say, look, blood pressure is an issue. I go through my mind and say, what else can be affecting the blood pressure? Have any of them that particularly cause blood pressure?
Spirit?
Perfect. So risperidone. Okay. That causes a measurable drop in blood pressure. When I start someone risperidone, I ask the nurses to do a sitting standing BP for once a day for 3 days after and fax it to me. Okay, oxazepam doesn't affect blood pressure. To my knowledge, it affects fall risk, but not blood pressure. Olanzapine does not affect blood pressure. It can affect fall risk through heart rate, through a different mechanism. Citalopram does not affect blood pressure. It can affect fall risk through other mechanisms. But the blood pressure one, because I'm being obsessive here, is the risperidone.
Yeah, I'm thinking back to that slide 2 or 3 back where you had the guy with the machete.
Yeah.
And I think in 5 minutes we could have this lady on a yoga mat only.
Okay.
I think these are all great things, but I think we also have to go slowly, as Chris mentioned a few minutes ago. So you've got eyes on the ground with the nursing staff who are going to give you really excellent feedback. Because you're going to be there once a week or once every 2 weeks or whatever. And they're really going to give you some terrific feedback.
So excellent, excellent point.
I think what Ted's getting at is that you're doing a scan of the whole profile, you know where you want to start, you have a sense of a plan, whether you write it down, that's what he's getting at. Because you don't have to go through all this thinking again. So if you actually have a bit of a plan, step 1, step 2, step 3, a little bit. Otherwise, you just have to go back. What did I think about back then?
So we can stage this over a couple of months, right? And prioritize what's the highest risk to this person. What are the low-hanging fruit that we can quickly get rid of? So I want to just show you a little tip I use. I use something called Hippocrates all the time. I've been doing geriatrics for 23 years. And I look up a drug, I look up every single day if I'm not sure about something. And what I do is I say, blood pressure is an issue, and I don't know, I know these drugs really well, but if I don't know about a particular drug, I'll double check the properties. Is hypotension a risk? Or is it renal excretion? Take me 1 minute to do that. And then I say, okay, I'll add that into my list. And that's something, if blood pressure is what I'm concerned about. So if we've got these 3 drugs here that may affect your blood pressure and increase your risk of falls, plus there's a whole host of other drugs that may affect your fall risk. We talked about prioritizing. We said, well, maybe start with the Flodipine. Chris said maybe reduce the dose of each of them without stopping one of them to see the impact on blood pressure, etc. And then the risperidone is sort of bugging me in the background. What are we going to do with risperidone? How would you approach that one?
Got it to once a day, maybe.
Okay. So you could first thing you can do is start with these 2 and see what happens a week later, because the blood pressure impact is going to be pretty quick. Then start with the risperidone. What would be the danger of stopping risperidone? Cold turkey. Would anyone stop risperidone cold turkey in a sliding? Within a month of coming in? Why? Yeah, or just the behaviors may become a huge problem, right? With this thing, we thought of withdrawal syndrome, but it can sit. So you'll see it a month later. Things are starting to weaken out.
One thing you can do with the risperidone is the nurses are becoming more used to, especially once they go to pieces of doing behavior tracking with simple tools. So you probably want to get them, before you start touching it, get them to do some baseline behavior tracking with the tool. And then when you actually start making the changes, you have an idea whether it's much changing or not.
So in the risperidone, in the goals of care meeting, I mentioned her behaviors are really good. She's a pretty happy camper, except when they brought her close to her.
But you still worthwhile tracking, because there may be certain times of the day when
Definitely.
it's all impression.
And especially if you can change, right? So risperidone is on our radar. In the edema, we talked about the Flodipine and caution with the hydrochlorothiazide. We talked about, just aside from her GFR is a biochemical thing we'll be treating. So the hydrochlorothiazide could affect your GFR. Are there any other drugs that could affect your GFR? Metformin, does it cause nephrotoxicity? No problems? So it is lower GFR? No, but you have to be careful with metformin because it's excreted through the kidneys. Any other drugs that you guys want to stop?
Aspirin.
Lipitor, why would we stop Lipitor? Pardon me? It's a really dubious value, right?
Yeah.
And Chris certainly talked about that.
Just point out that our thinking now has changed from dealing with symptoms to dealing with future events, which is what Chris's model was sort of, or structure was sort of pointing us towards.
So what about symptoms? If we say, so look at her symptoms. She's unsteady, right? And that's a goal in their care plan. What would we do? What else could we help her with her balance? Good. So there's the balance now. So part of balance is blood pressure. The other is oxazepam. Anything else that could be affecting her balance? Citalopram. Okay. Anything else that could be affecting her balance? Okay, she's anemic, right? So her hemoglobin is 104. That may reduce her energy reserve and her ability to walk and balance. So we'll put the anemia, the iron deficiency. Okay. Good. So we've got the balance. And let's look at that goal plan again. The confusion. Is there anything that can make her dementia worse? Anything? Good. Okay. And some of those drugs we may not know, the composite, like Chris said, if you put a whole bunch of things in a person's body, there's some things you just feel lousy, you don't think well, you're not feeling well. Okay, the anorexia, the unsteadiness, the anorexia. What can we do for the anorexia?
Reduce the metformin.
Okay.
People under
So you said reduce metformin. Okay. How can we handle? So one way would be is to reduce the dose.
Yeah, reduce the dose.
Okay.
You can try 500 mg.
Okay. How low can you go with metformin? I thought some people do 50, or you could stop it. Right? Any risk of stopping metformin? Cold turkey?
No.
No, exactly. What's the worst thing that can happen?
Blood sugar will change.
Okay. And what blood sugar would you be concerned?
I would only be concerned if she's symptomatic with polyuria, polydipsia, or anything like that.
Okay. I think Deb's going to talk about diabetes, right? So I'm going to leave that to Deb, but just to think about that, right? Okay.
So I have a question, like, if somebody has already blood glucose and not in good control, if there is hyperglycemia, that can cause gastric stasis and over time gastroparesis. So we need to know the numbers, what's the blood sugar numbers.
So blood sugar, your A1C is 5.5. If we did a fasting, I'm going to say it was 6.
Okay. Like
Okay.
a GFR, like
We'll
for pharmacy, a GFR, if it is less than 30, then you can discontinue metformin. Otherwise, if you don't want to start like injection, like if you want to give insulin for diabetes, like we can still avoid injection if we are using metformin. So it's give and take.
The whole discussion around the goals of treatment in this age group for hyperglycemia. Yeah.
Well, she's 90, so.
Yeah, so we're going to come back. Dave's going to talk about targets, because a lot of the targets for young people do not apply to old people, and they become worse. In fact, a lot of targets for young people don't apply to young people, we're starting to see. So we're going to come back to that. Okay, so let's talk about anorexia, because this is really important. I love to eat. That's one of my pleasures in life. Right? And these people, everything's taken away from them. Now she doesn't even like her food anymore. Right? And she's losing weight, which is making her weaker. Any of her other medications, so we talked about medications that can like metformin. Anything else?
Galantamine, possibly? You might
Galantamine,
consider
definitely.
something that-
Anorexia is a complication from galantamine. All cholinesterase inhibitors can cause anorexia. Great. So the metformin, galantamine. Anything else?
How about alendronate?
Where's alendronate? What does alendronate cause in the GI tract? Exactly, it's an acid. Alendronate is a very low pH drug, and that's why you don't want it in contact with the esophagus, which has, columnar epithelium, whatever it is. So, and if people can't stand up after eating it, it just sits there. Do you think demented people are going to assume the right position for the amount of time? No. Okay, so let's put down alendronate. It definitely causes, I can't tell you how many times I see alendronate in people. They have nausea, anorexia, discomfort, non-specific symptoms, and it's related to the alendronate. And I'm going to come back to the alendronate issue. If we stop alendronate, what's the risk? What do people want to say? What's the risk? What was alendronate being used for? Let's come back to the indication and risk. What's alendronate used for? Osteoporosis, it's only one thing, and forget osteoporosis, it's used to prevent fractures. That's the hard outcome. That's the quality of life outcome. Painful vertebral fractures, I don't care about morphometric a little bit, because people can have trouble breathing, and hip fractures, right? So I don't care about the bone density change, but that's what will underneath. Is this lady on it for secondary prevention or primary prevention? Primary. So, good rule of thumb, primary prevention always takes a lot longer to treat people, and you need to treat a lot more people for a lot longer to get a benefit. How long does it take, and this is what Chris talked to, time to treatment. How long does it take in a placebo-controlled trial where one group, let's say someone's had a hip fracture, and one group gets a lendonate or zoledronic acid or bisphosphate, and the other group gets a placebo? How long does it take for the group that gets treatment to show benefit?
6 months.
There's about a 40 to 50% risk reduction.
6 months.
So the vertebral fracture curve starts separating 6 months. They're not statistically significant until about a year for vertebral fracture. How long does it take to prevent a hip fracture? 2 years. Okay, there's no statistic. They don't separate after a year. So the way to determine time to benefit is you really need to go back and look at the clinical trial data. And you'll see what will happen is typically this will be a treatment arm. This is a treatment arm, and this is the placebo arm. Pardon me, it should go the opposite way because it's a reduction. So the treatment arm will show a reduction in hip fracture, right? And the placebo arm will be about here, right? There'll be higher number of events occurring. And then this time point is the time when the curves separate. And that's how you can do it. And then they'll even tell you when is it statistically significant. Okay.
How about the time to harm when you stop it? Can you say anything about that? So you're stopping the drug, what's her risk?
If it's acidic esophagitis, how long will it take to feel better?
I'm speaking about, I'm thinking more about fracture risk. You've got her on it for fracture prevention. What's her,
Okay,
when,
so
how fast is she going to get back?
Let's come back. So the absolute risk reduction, you might look at the zoledronic acid, recent one, zoledronic acid after hip fracture, which is the best benefit. Someone's had one hip fracture, the highest risk group possible. They get IV zoledronic acid, yearly for a couple of years. And the other group doesn't get zoledronic acid. So the absolute risk reduction, the highest risk group, people who've had a fracture, we're talking about 5% over a couple of years. 5 to 10%. Most people don't have another one. So they're small. The absolute risk reduction is fairly small, but it's important. If it's me, I don't want to break another hip. Okay.
You take into account whether they, have ongoing balance and, the falls risk and that kind of thing.
If they're ambulatory, if somebody in residence are not ambulatory, if they're not ambulatory.
What's the risk? Exactly. Yeah, I'd be more concerned about vertebral fractures.
Looking at the steps, even though it's low dose, the coated aspirin may be a factor there.
Absolutely. So aspirin, don't underestimate how important aspirin is. We think of it as mother's milk, but 81 milligrams of aspirin. We had a lady, I've had a couple of people now that have bled right down to very low hemoglobins. I had a lady who was on nothing but aspirin, and she went from a normal hemoglobin down to in the 40s. Okay, and there's no other reason. She had multiple ulcers when they scoped her, and that was from aspirin that did that. So baby aspirin has a risk associated with it, particularly in a frail population. So I would say aspirin would be something to consider. In my mind, I would say if they're nauseated, not eating, do they really need the aspirin? For her, it's primary prevention, right? Is there any evidence that aspirin prevents events like stroke and heart attack in primary? There is a little bit, but it's very mixed. Is there evidence in this group? In the elderly population, there was one clinical trial published out of Japan just a few months ago, which showed no benefit for primary prevention and harm because people had bleeding. Anything else that could be affecting her appetite?
Just constipation, you can take calcium on.
Okay, so constipation, calcium, great. Okay, and
How much do you see EDS affecting swallowing with risperidone?
affecting what?
Yes, affecting swallowing and ability to.
It definitely does in people.
Risperidone.
Yeah, risperidone can affect coordination of swallow, especially when you increase the dose, or if someone's got a neurodegenerative disease to begin with.
Also GI side effects with citalopram.
Citalopram may cause anorexia and nausea, so you could put that down as Okay, with people stop the cyclopram here. So far, we've brought 4 new drugs that we could stop with low-hanging fruit, right? Alendronate, we could stop. You know, the calcium, the aspirin. You know, nothing's going to happen right away, right? If we think about what's going to possibly put her at risk really quickly if we stop it, what won't. So we could stop the ones where there's no immediate risk to her and see what happens. And maybe her appetite will pick right up. And then if it's still a problem, come back and say, let's reassess the cytopram. Right? Anything else affecting her appetite? Okay, what's the next one? Constipation. What could be causing constipation for her? Anything?
Calcium, I already said that.
Calcium, major, big cause of constipation in people. Okay.
For hydration is.
For hydration is probably poor, you know, her intake is poor.
Interaction, all those pills.
Okay. What about Polypharmacy?
Yeah, just
Polypharmacy, definitely calcium channel blockers and constipating for a lot of people. Okay. So we've got a couple of pills. Okay, now we've gone through her problems and the edema, we talked about the Polypharmacy. Now we've done that run through, problem-based run through of the drugs. Now let's look at the rest of it. Do we really need any of these drugs that we haven't even talked about? Does she need ARIDS vitamins? Have you ever seeing how big those vitamins are? They're huge. They're horse pills. Most people can't, so they end up crushing them to get them into them. What are those vitamins used for?
Generally, it's for prevention of progression of the macular degeneration, but I talked to actually Andy Burnett about that. He said that people are stuck on them all the time for minimal indications. So in his practice, he's a retinal specialist. He only actually uses them for individuals who are probably, or he would say, moderate to severe. So primary prevention, a lot of people aren't for primary prevention.
Yeah, there's very little evidence that they're useful for primary. These are fat-soluble vitamins. What do we know about beta-carotene and, you know, and some of those vitamins, antioxidants? They increase mortality. You got all these people going on these drugs. So you apply to thousands of people. Someone's going to get them hurt, as Russell Peters would say. But the ARIDS, so we're talking about a very low risk of, you know, we're talking about a couple of people per 1,000 users will not go from dry to wet macular degeneration. Should we get rid of the ARIDS vitamins? Right? She doesn't like eating, and she gets anxious at all time. That's something, a low-hanging fruit that I would pull away from her. What about the allopurinol? What do people think about that?
You might want to decrease the dose and see how she does, because she has documented it out, right?
Okay, so allopurinol, we're away. We don't know what it's doing symptomatically to her functionally, but it's a drug that's there that may be causing trouble. It's excreted through the kidney. So it'd probably be pretty reasonable to reduce. Would anyone want to stop her allopurinol?
Not initially.
Anyone?
I would leave it till much later because we
Yeah.
have so many
Yeah.
bigger issues and we don't want her getting gout and having to
No,
treat her
no,
with
no.
pain meds.
Respect. So allopurinol can really, you know, prevent a bad outcome. And gout is awful for people. And you'll see them, they'll flare within a couple months of stopping it. So that would be down on my list, unless, let's say, she had a macrocytic anemia with a hemoglobin of 60 and her MCV was high, because allopurinol can suppress the bone marrow. But that's not the case with her. Peter?
I don't know if it's been discussed much, but the galantamine, it might be good to check with family if they actually saw a terrific amount of benefit with it.
Okay,
And
perfect. So we went back to the family. They thought she was a bit better when she went on galantamine. You know, she was more organized. Her conversations were better. They thought she was better when she went on it. But there's a lot of people that are on cholinesterase inhibitors. They don't do anything. So, but they're just layered on. Someone said, Jeff says they take a life of their own, and you just layer on another drug and another drug. But this case, the family said they may have help. But that's a great point you're asking. Okay.
I generally, when people ask about withdrawal of galantamine, I generally suggest that you wait 3 months until it's, you know, the move to residential care is so huge and it can be very disorienting. But at 3 months, I think, you know, if you don't feel that it's made any benefit, especially if they have advanced dementia, they're of questionable benefit at that stage in their disease. You might as well start withdrawing it and see, drop it down to 8, wait a month, see what happens.
Thanks, Dan.
But I generally get a little.
And remember, so that's a great point. I generally don't stop cholinesterase inhibitors during the transition. because it's hard enough for people to adapt to going into a nursing home. And then I'll wait, and then I'll say, okay, now everyone knows this person really well. What's their baseline function? We saw she could make it to the toilet, she could do this, she could do that. Then let's pull back and see if something changes. So we basically said, for her fall risk, and her balance, we thought her blood pressure was really low, so we could deal with the fluid hydrochlorothiazide. For the fall risk, I know my writing is horrible. Yeah, we've got oxazepam, we've got citalopram, which we're going to wait for. We can look at her anemia. She's not feeling very well. For anorexia, there's a whole bunch of things she's on. We don't have to take it all away at once. And her calcium, her metformin.
You're going to do some dosage reductions in some of them.
And some of them we're going to do dose reductions. So let's see.
Just a quick question. This seems to be the third step in what you do. I mean, you've got your assessment, you've got your goals of care to get you this far. And then you have, you've made yourself up that information, you put it together, and then you're doing the med rep. It's almost like, can you go back a slide?
Sure.
It's almost like you have a little a worksheet. Do you actually put it together like this, physically?
I do. A lot of it, you can see how complicated this is, right? So we use Oscar. So I have a problem list in front of me, which are the list of the problems, in their, not reminders, one that's beside reminders. That's called issues, so that's where I put the problems, and that's where I put from the care conference or the goals of care. And then I've got the drugs all there, and in that problem, I'll put drugs. In my mind, I say, this drug, I'm not happy with this, anorexia caused by metformin and glantamine and this,
So you do that match.
I do that, and then I look at the whole thing, and then I say, like what we've been doing is, okay, some of them I can get rid of right away. Some of them, I've gotten back to my mind, maybe a problem if the first wave doesn't make any difference, I'm going to come back to them and reduce them, but I'm afraid if I stop it, they may get worse. So I'm going to keep that as step 2. Some of them, I need to talk to the family a little bit more about, because bad things may happen, if we stop some of them.
I think there's a practical technical issue as well here, because you don't have that, you don't have the EMR in residential care when you're there. So I think that would be something to kind of tease out.
But before I had an EMR, I would do this on a piece of paper.
Well, that's what I'm getting at, right?
Yeah, on a piece of paper.
It seems to me that doing it properly initially, as much as you can, then will save you a lot of time later to actually have to go back and review it again and try to figure out what your thinking was as opposed to what you wrote down.
And I want to mention that the EMR does not prompt me to do any of this. So it's not the EMR saying, oh, they're on this drug, like we think it was a really intelligent EMR. But it's just trying to map out, here are the problems, here's what I think, my hypothesis is what's contributing to the problems from a drug perspective, and here are what we're going to try and do in a staged fashion, and reassess this in an iterative process. So in this lady, this is the summary of everything that happened with her, in terms of starting with her drugs. And we talked about last time about what was the anticipated efficacy, why were the adverse effects or problems that we wanted to stop the drugs, what was the impact of changes. So, we basically ended up stopping 7 drugs with this lady. We stopped the ARIDs and the calcium, and the impact of the change was her pill burden was reduced. She used less laxative. We stopped the alendronate for the nausea, anemia, and because she was probably getting a little GI bleeding from the alendronate as well. And swallowing issues, and her appetite and weight had gone up. Her hemoglobin went up to 136, and we'll talk a little bit more, because there are other things that did that. We stopped her atorvastatin. She didn't really complain of any muscle pain, which is, so if I have someone has muscle pain or I'm concerned about pain, and they're on a statin, I stopped the statin. People, because quality of life, regardless of what the cardiologist says, I'll stop the statin.
Ask them how they are in a couple of hours.
And then reassess them, exactly. The aspirin was stopped, her hemoglobin improved. That would certainly contribute to her anemia. Her appetite was better. The fluoxetine hydrochlorothiazide both ended up being stopped. And her blood pressure was 146 or 72, which is in range for someone in her age. And her edema didn't get worse. She had +1 edema. In fact, it got better. The edema was less because the calcium channel blocker stopped. Her metformin was reduced from 1,000 to 250 BID. When we actually stopped the metformin, her blood sugars went up to 19. And my experience is when people are getting into the high teens or low 20s, they may not have polyuria, but they're not well. And you'll see them, they'll lose weight. They become catabolic from their diabetes and can affect their quality of life. So they're getting into that range. That's something you say, put her back on. 250 was enough to get her down, and her A1C came up to 7.8. Her fasting blood sugar was in 9, 8 or 9.
David Miller, one of our endocrinologists here, he's got a kind of a rough guideline for hemoglobin A1C, which generally about a tenth of the age of the person. As opposed to going with a keeping diabetic, you got 5.5.
Yeah, so 5.5 in my mind would be a very dangerous A1C in the person in this age group, or actually in a lot of people. The allopurinol, the dose was reduced to 150 milligrams, and because of the reduction in GFR anemia. The oxazepam, we got her down to 7.5 milligrams at bedtime. And when we tried to stop it, she was exhausted the next day. Some people need a little bit of oxazepam to sleep, and the family thought she was worse, the staff thought she was worse, so we got her back on. Big difference between 30 and 7.5, huge difference in terms of fall risk, in terms of cognitive impairment. Well,
So just going back to the blood pressure, I'm just curious, do you worry when someone's been sitting at, let's say, an average of systolic 100 or 110, and then you stop your antihypertensive and they're suddenly sitting at an average of 140, 150? Do you worry about that sudden shift for the heart and brain?
not at all, Molly. The 110 is much stress, higher stress in our heart to get everything up to the brain, the other organs that are vying for blood. What I sometimes see, though, is I'll see people that are low, 110, 120, and I'll stop them, they'll go up to 190, 200. And I've seen people with hypertensive encephalopathy, in a residential care environment, where suddenly they're just not getting out of bed, they're not talking anymore. And in fact, because their blood pressure went up so high, But I don't, I'm not worried about going up into, in fact, most people say they feel so much better, the ones who can articulate it.
So what's a good target for this?
I generally go 140, 150. A lot of people say to 160. I'll tolerate in the 130s, in the low end of things.
On the question of metformin, I had a recent case of med review, and the patient similarly had a pretty good A1C, and the family was advocating discontinuing it. But I suggested that they should continue because they also wanted him to not have to be strict about diet and to enjoy candy and so on. And I said, okay, fine, we can be very relaxed about our target A1Cs, about 8 or 9 would be fine, but I'd be reluctant to stop the metformin, because then we'd have to be more strict about diet control.
And again,
would you think that's reasonable?
Yeah, I generally don't like to restrict diets. Again, I'm a big eater.
Right.
So I don't want to reduce something that I rarely restrict someone's diet in geriatrics.
Yeah.
Rarely. And I think your point, if that's going to help them eat what they want without making them sick.
Yeah, that's basically the argument I made, and convinced the family that we should continue metformin, but I did reduce the dose.
So elevated blood sugar could also cause polyuria.
Yes, definitely. And it does happen in this age. Why is polyuria less an issue in an older person compared to a younger person? Why don't we see it until their blood sugars are much higher? A physiological question. Because their GFR is lower.
Yes.
Right. So I see people in the 18s, and they don't have polyuria, whereas someone else would definitely have polyuria. So just to move on, we also ended up trying to reduce risperidone with this lady because of her fall risk, the blood pressure impact, the mortality risk with antipsychotic drugs, which is real. And we got her down to 0.25. She was on 0.5 BID. And once we got her below 1.25, her agitation escalated, and we took her right off it, and it was clear she was not a happy camper anymore. And so we put her on a maintenance dose, and every time we tried to bring her back off the point, off the risperidone altogether, she started to get revved up again. So that's as far as we can go with the risperidone. The citalopram we were able to lower from 20 to 10 milligrams. When we stopped the citalopram, her mood got worse. Staff were reporting she just was avoiding activities, and her mood was worse.
And did you try 5 milligrams of citalopram?
I left it at 10 with her. That seemed to be the one. So you could go down to 5 if you wanted. But I didn't see it as a big risk at that issue, that level, and I didn't see everything else had gotten so much better. The galantamine, interestingly, because one of that article that Chris referenced, that cholinesterase inhibitors should not be used in long-term care, say, full stop, right? They're a waste of money, and they don't do anything. We stopped this lady's galantamine, we took her off the galantamine, and she did terrible. She could no longer toilet herself. She had no idea where the dining room was. She didn't even know how to use a walker. She couldn't carry on a conversation with her family anymore. And I got a call from the family saying, what happened to Mom? Is she got a UTI? But in fact, it was stopping a glantamine. And the thing when you stop a cholinesterase inhibitor too, to think about is, watch carefully those first couple of weeks. Because if you wait 3 months and then try to restart it, let's say you don't do your next visit for 3 months, things are so discombobulated by then, it's really hard to get people back to where they were. But if you need to put her back on the cholinesterase, and it came back to the values, their value in goal of care was that she would maintain function as long as possible, right? And she lost function, and there was more work for the staff, so we put her back on the galantamine.
And there's, with that class of drugs, there's, families may say, well, you mean there's no hope, you're giving up on my mother, my father. So there is quite an emotive relationship to cholinesterase inhibitors. And as we've gone around the province with Polypharmacy, some care facilities will say, we're absolutely not touching that medication. Now, we don't advocate that, but just so you know that there's, and that's family values, people's own values that come into that class of drugs more than others.
So the last drug is a STARP. And I put this lady on ferrous gluconate. Her hemoglobin was 104. I think anemia, especially if it's a subacute, will affect people's quality of life. We see it can cause other issues. And we treated her for 3 months. So we treated her with BID ferrous gluconate, so her hemoglobin normalized, and treated her, repleted her iron stores for another couple of months, and stopped the ferrous gluconate. And the downside risk, what's the downside of ferrous gluconate? Constipation and anorexia. Right, so we needed to sort of monitor that. And her hemoglobin normalized at 124.
One of the things, looking at allopurinol back there, I would have stopped that after stopping the hydrochlorothiazide, because it precipitates gout so much. It's one of the major side effects of HTC.
Okay, so that's the thought. I've seen so many people flare with gout, and they've got so much body burden of uric acid. And hydrochlorothiazide is going to stop will help a little bit stopping it because it increases uric acid in the body.
Yes.
It's a thought. It's not an unreasonable choice.
Ted, do you actually put that in the chart, that chart into the patient's chart?
No, I'm just summarizing it.
You're just summarizing it. Oh.
So just to look at our stats, 7 stopped, 5 reduced, 1 no change, 1 start. It's not bad. It doesn't always happen that way.
So what would be your advice in the residential care environment on working with nursing and pharmacy as you're going through that? You don't want to call from the pharmacist saying, oh, well, questioning what you're doing, for example, and the nurses are involved in the monitoring plan. Just to give a sense of that, because when you're approaching it as if you're doing this all, but you're not.
I'm making the decisions. You're the doctor. I'm going to disagree with Chris here. And I'm just put you back in the saddle. Because there's a tendency that you're like a sideshow.
No, I'm not saying that. I'm just saying it's collaboration.
Yeah, no, definitely. So definitely. So the pharmacist in the review, it made some suggestions. The nurses, they do a lot of the follow-up. They told me that, they also told me, this person doesn't like swallowing all these pills. Yeah, and the nurses are really instrumental in healthcare aides also. I'll say to that, to follow up, when I check someone's mood, I'm concerned. I speak to the healthcare aides when I do my
And that's what I'm getting.
repeat visit. Totally, yeah. 12 months later, it's time for another family conference med review. And her function, there was little speech by this stage. Her dementia progressed significantly, or language. She was wheelchair mobile, needed to be reported to the dining room. She was total care now for her activities of daily living, needed to be fed. Medical change, she'd had aspiration pneumonia 3 months ago. The goals of care, there was no change. Comfort was paramount. What's her prognosis now? What's her survival? 6 months, right? So she's really dropped down. She's palliative, right? Clearly. So these are her current medications after all of our first wave of slash and burns and tapering over a couple months. And it took three months to get her drugs down, 2 to 3 months. It was vitamin D, metformin 250 BID, allopurinol, oxazepam, risperidol, citalopram, and galantamine. What drugs would you want to stop and what would you want to continue? Steady?
Vitamin D.
So vitamin D, definitely.
Allopurinol.
Pardon me?
I would stop allopurinol.
Allopurinol, sure.
Oxazepam.
Okay.
Sit down.
Okay.
Citalopram.
Okay.
And continue with risperidone and galantamine.
Why would you continue with galantamine? Let's remember,
If the family, you've got to talk to the family about that.
what's the galantamine doing for her quality of life and function at this stage? This lady's 100% care, no language. Will she start on galantamine?
You
Okay.
can
You
stop
have a
it.
discussion and then you say, this is, if you agree with this is what we're going to do, stop the medication.
Exactly. So
Because
this is
there's no
why
way-
somebody's going to stay on even at this stage. And really, at this stage, what is the palpable or measurable possible benefit is zero at this stage. So unless she gets more agitated.
And also, it's not covered once they're in the CFP, so sometimes with.
Exactly, there's cost to this drug. So in fact, with this lady, we stopped everything except for oxazepam. We tried to stop oxazepam. She was more restless at nighttime, and the care workers were reporting that. And we actually put on a little bit of acetaminophen because we thought she's sitting in a chair all day. She was probably a bit uncomfortable, which can contribute to some of her agitation. We talked about that the last case we did last month, or a couple weeks ago. So, Ian, how much time do you have?
Well, we've got about 5 minutes, so you can't do a full another case. We should get Debbie Annie's turn.
Okay, yeah, so what I'm going to do is there's 2 more cases for you guys to work through. I'm just going to quickly, and I want to just summarize here. This second case is someone with a lot of chronic symptoms, chronic diseases, who's mentally with it. Basically, you could tell you what she wanted. And she wants to be able to see her grandchildren interact with her family. It was on a whole slew of medications that she was on for many, many years, and was on oxygen, etc. And 2 points I want to make is amitriptyline is a drug that's a lot of people are still on, and they've been on it forever, and it helped them. And it comes back to, now it's causing problems as people become frail, because before they could regulate their blood pressure. Now they can, so it causes postural hypertension. It's anticholinergic, it can cause confusion. So a drug that was previously well tolerated is not well tolerated. The other thing I wanted to just share my experience, another drug that loses, this is about drugs that cause problems with age. Digoxin may have been fine at 0.25 milligrams, which was younger for to control her AFib. My experience is that is a high dose in an older person, and most people can get away with 0.0625 milligrams. And a lot of that is people lose muscle mass and the renal function, and they get digoxin toxicity with normal levels. And the only thing that's going to present with is anorexia and loss of appetite and maybe more confusion. And the last drug I want to point to you is the insulin. This lady was on Lantus insulin, and a lot of people will have night sweats. And we say that Lantus doesn't cause hypoglycemia, but that's not true. And a lot of these people, their A1C is 7 or whatever it is. And we've seen about half a dozen cases in the last year, Fiona and I, where people say they get night sweats in the middle of the night. They're not going to double check their blood sugars. I lowered the dose of insulin by 25% right at that, as soon as I hear that. And sometimes 50%. And I can tell you every single one of the cases of night sweats is going away. So don't be fooled that Lantus doesn't cause hypoglycemia. Sorry.
Just on another note, though, with warfarin plus ASA combined, that's something that makes me really nervous.
Yeah, this was another point of this case, because we're running out of time, I'll just mention. Never use dual antiplatelet therapy. Be very careful in this age group. Most stroke people will tell you be very careful in people. Warfarin and ASA, you have to be extremely careful, and I rarely use it unless someone has very unstable angina and atrial fibrillation. That's the only time. And then I'll monitor their hemoglobin very carefully for that group of people. So you guys can look through that. Those are some of the key points from that. And there are other sort of nice little tidbits there. Case number 3, very quickly, was a guy with dementia and chronic pain. We had no care.
Before you whip through this, we are going to have a question and answer period. So you could walk us through it later.
Okay.
And then we get the pleasure of, and the learning opportunity of going slower.
Okay, so I'm just going to conclude my presentation. And basically, to give you guys a framework for medication reviews. The first thing I do is start with the comprehensive geriatric assessment. See, these are new patients for you, or they may be old patients that need a real good review again, because they've gone into care, to try to define the problems, and establish the goals of care, and then prioritize. The goals of care help you prioritize what the problems are for the person and their family and the staff, right? Who you're trying to help. And then do that medication reconciliation. If there's an orphan drug that doesn't match the indication, get rid of it. But keep in the back of your mind, maybe you just don't know what that diagnosis was, especially if it's a cardiac medication. The second thing is a good outcome is not necessarily a drug count, right? Sometimes we stop drugs and people get a lot worse. So don't look at it purely as a drug count. You know, match the, you know, what we're looking at with multiple medications is matching the right drug that's effective for the right problem and the right goal of care. That's what we really hope to do with people. And getting rid of harmful, ineffective, unneeded drugs that are not consistent with the goals of care, if you can keep that in mind. The third thing is that previously tolerated drugs can cause severe adverse effects, and don't underestimate that with people because of changing kinetics, changing pharmacodynamics, and layering in new drugs and drug interactions. The other point is to stage your changes. Ask yourself, there's no burning rush, but just keep following up with people. Some things you need to move quickly on. If someone is falling all the time, you need to get their blood pressure up, and you need to lower that fall risk, right? Or if they're really agitated or something. So start with the low-hanging fruit, for example, the preventive medications and the vitamins, the big gulps, you know, they have to take in at the time. And then prioritize drugs that are significantly affecting their quality of life and their goals of care. And then taper to the lowest possible dosage you can get them to, or try and take them right off the medication over, you know, a month or two. You know, particularly be careful with psychoactive medication, pain medications, and cardiac medications. So you want to see, as you taper those drugs, do they get worse? And then finally is to say is that follow up on all of your changes. And this is the difference here. And you guys are in a position where you can come back and see people again. Is that, and use the staff. Like Chris was saying, we work with the team. So anytime I change a drug, I ask the staff to the facility fax me back with what's their blood pressure, heart rate, weights, behavior mapping, their target symptoms, and they'll let you know a week later. You know, in case you're not able to get in for a couple of weeks after a drug change, so you can sort of nip things at the bud. And then be very cautious with delayed relapses. So some drugs you'll take them off on, they'll do a lot better. But if it's a psychoactive medication, they may not relapse with their depression for 2 months. You know, and then it's going to come back with a vengeance. Or if it's similarly with agitation and psychosis, it may be 4 to 6 weeks after stopping the drug that you run into problems. And just remember that this is an iterative cycle, and then repeat the cycle. These people, their condition is changing. You know, over time, there may be an acute event that really changes them, you know, their total functional status and level of frailty. Every time there's a big major acute event, reevaluate the whole picture again. And then once a year, you know, a couple times a year, is think still need these medications. So that's the way, you know, I try to approach the medication reviews.
Excellent, thank you.